This is the second recording or lecture for your introduction to pharmacology. Pharmacology is the study of drugs and their actions on the body. So we're going to start talking about pharmacokinetics. Pharmacokinetics is what the body does to the drug, how it moves through that body: absorption, distribution, metabolism, excretion. Pharmacodynamics is what the drug does to the body: receptors, ion channels, enzymes, immune system. In your little exercise that you will do next week, it's all about pharmacokinetics and made a fun activity, so hopefully pharmacokinetics will make more sense. I was going to cover pharmacodynamics, and that's why I have a lecture on the autonomic nervous system, but I'm saving that for the summer. When we start into pharmacology, we're going to start with autonomic nervous system so that we can look at the receptors and enzymes, immune system, all those things you will get throughout pharmacology. So defining some of these. So absorption is what happens to the drug from the time it's administered into the body until it reaches its target, the circulating fluid and tissue. Distribution, it's how is it spread or distributed around the body. Your some other things that go along with your pharmacokinetics and pharmacodynamics, as we go through here, you'll have your receptor sites, which is mentioned over here, which is they react with the chemicals to cause an effect. You have critical concentrations, which is how much is needed. It's your therapeutic effect and how much is needed to make that effect. Some drugs need a loading dose, which means you give them several doses for several days in a row until you get to a therapeutic range, to get them to that therapeutic range faster. Okay, I'm not going to go further into this right now. So, pharmacokinetics, the study of what the body does to the drug, the absorption, distribution, metabolism, excretion, ADME, the fate of the drug. I liked this little thing. How will that stuff get from down there up to this sore throat? So your pharmacokinetics. Few things in here. Where you take your drug, it's administered in different routes: oral, intravenous, peritoneal, subcutaneous, intramuscular, inhalation. It can be given in a suppository. It can be given topically. I think I'm forgetting a route here right now. Inhaled. So then it goes absorption and distribution. Membranes of the oral cavity, GI tract, peritoneum, skin, muscles, lungs all have something to do with the absorption and distribution of the drug. Then you get into all your receptor sites and your binding. So we will only cover a little bit with your binding, and some of that will be evident when you do your activity. Some gets deposited in the bone and the fat. Some are bound to protein and they can't be used right away with the body. Then you excrete it. Your intestines, kidneys, lungs, sweat glands all have something to do with your excretion. Your liver has a lot to do with metabolism, your inactivation, with your first pass effect, which we will talk about. What else do I need you to know? Do I talk about... I do have it broken down when we talk about half-life. Okay, so I'm going to keep moving. This is just giving you a visual image, like a 50 milligram drug that is injected, administered, and there's tissue binding, plasma protein binding. all these different things that affect how much actually gets through. So very little of this drug that ends up unbound and actually gets to where it's going. Your R's of drug administration. Nurses have a lot of responsibility when you're giving your drugs. Drugs can be given enterally, which means it's given into the gut. Whether it's swallowed in their mouth, somehow it goes from the mouth to the GI tract. Enteral can be enteral feedings where you're doing a tube feeding but it's going down to the gut, or you're putting it in their mouth and they're swallowing it. The advantages of enteral is safe, it's inexpensive. Unfortunately, it can be a slow onset. Might have a low bioavailability, which means different acids in the stomach break it down too much or block with the absorption. And then if you have to trust a patient to take it so many times a day, there can be non-compliance. Always keep in mind the more times a day it has to be taken, the decrease in compliance. There's the parenteral route up in here, parenteral, which injection. Various injections, IM, sub-Q. The advantage is compliance. Usually it's like a once a day and they're more likely to do it. It has a rapid onset of injection, rapid onset of action, and a high bioavailability because it doesn't go through the liver, so it bypasses the first pass effect and more of what you actually give gets into the body. And that also why it's an onset is faster, because it doesn't have to go through the whole liver for absorption. You have you see here, parenteral is your IM, intradermal, your allergy shots, your sub-Q. Then you have your IV. IV goes into the vein. It's intravenous in the vein. It's very fast, has a rapid onset, and complete delivery. 100% of what you administer is 100% bioavailable to the body. It might have some flexible rate of absorption administration. Disadvantages: once you stop it, once it goes in, you can't take the medicine back. So if like they overdose on aspirin tablets, you can give them charcoal or something to stop it in the gut. But once you give it IV, you can't take it out. So there's a high risk of having an anaphylactic type of reaction. There's a risk of infection because when you're administering into the vein directly, any contaminants can go in also. You have your intramuscular, which is a type of parenteral like your intradermal, and your sub-Q, and intramuscular, various places it could be given. It has a rapid absorption and a rapid onset of action. It's just with a lower muscle mass in elderly, they may not absorb and have as fast of an onset. You need a good blood flow to the muscles to make it, to help with absorption and action. Disadvantages: you can only give so many cc's in a muscle, 3 cc's max, and it's painful. Your subcutaneous, another parenteral, given under the skin. Uptake is similar to intramuscular, but a little bit slower. Unfortunately, in subcutaneous, it's not a steady absorption, so it can be a little erratic. It's a good place to do sustained release drugs because it's absorbed a little at a time. It still can be painful, and it can cause tissue damage. Intrathecal, you may have seen this in OB, because it's given into the spinal column. It's difficult and dangerous. It can cause spinal injury. It's useful for central nervous system infections and for spinal blocks. Of course, you have your topical. Right here, your transdermals. applied to the skin. It's in a patch or an ointment. It's only limited into lipid-soluble compounds. It's the only thing that can be absorbed through the skin. And when there's thinning of the dermal layer, like in the elderly, or broken skin, there's increased absorption. So there's an increased risk of toxicity or getting too much because of the skin. Here it says transdermal solutions, spirits, syrups, elixirs, suspensions, emulsions, lotions. Okay. Intranasal is given into the nasal cavity, a rapid uptake, usually decongestions, some hormones can be given that way. Inhalation, those are limited to gaseous aerosols. The advantage is it's rapid, it's efficient absorption, it has a passive diffusion right through the alveolar membrane in the lungs, which is a large surface for absorption, so it increases the amount of drug that can be absorbed that way. Pharmaceutics, drug dissolution absorption. So the liquid oral preparations, these are the different forms. The fastest is a liquid or elixir syrup because it doesn't have to be broken down. And this just lists them in order of the decreasing in how rapidly it absorbed. Of course, enteric-coated capsules and extended release tablets are never crushed. The capsule is in a capsule form for a reason. There may be that it needs to get further down past the stomach into the small intestines because maybe the stomach gases will break down the medicine and destroy it. Enteric-coated, again, could be that reason, or more likely it's like an aspirin that's very acidic and can be very damaging to the gastric lining, so it's coated so it's not broken down in the stomach but broken down later. Extended release tablets are done that way. They're extended release. They are not crushed. They're the slowest absorption because they're supposed to be released a piece at a time over a period of time. Now keep in mind there is extended release and slow release, controlled release, SR, CR, XL. So really be careful with those. A slow release and a controlled release tend to be the same. They may be given 2 or 3 times a day. An extended release is usually once or twice a day because it's an extended period of time. These are released slowly, but extended release is over an extended period of time. So I've mentioned before the first pass effect, which is your hepatic circulation. Mostly you think of your liver. The liver is the single most important site for biotransformation or metabolism of a drug. It breaks the medication down, helps to prevent medications from causing adverse effects on the body. It's their first pass effect. So the drugs go in. If they go through first pass effect, it metabolizes the drug, and a certain percentage of that drug is lost to this metabolism and excreted or wasted. Oral drugs, drugs per os, per the oral route. Some are lost with the acids in your stomach. Then they get into your liver, and they lose some in your first pass effect, which is excreted, metabolized and excreted in your bile and then your stools. And then the rest that is absorbed in that portal system goes on into your circulation, goes through your right side of your heart, to your lungs. Some can be excreted in the air from your lungs in that whole alveolar exchange. Some drugs take in the mouth inhalation and right into the lungs. Then everything goes through your left side of your heart, pumped out to your body into your systemic circulation. Some of this is then it is excreted through your kidneys. If you give a drug IV, IM, subcutaneous or transdermal, it bypasses first pass. It doesn't have to go through the liver, so you don't lose some of it in the first pass effect. It goes straight through the rest of the route, so more of it's absorbed. Here's more on your drug administration. You have your oral, which goes into your gut and then comes over into your vascular system. From your vascular, it can go into your hepatic for your first pass effect metabolism, out in the biliary, intestinal, and then through your kidneys. And your intravenous bypasses all of this and gets into distribution. Protein binding. Protein-bound molecules are not available to exert pharmacological effects. What does that mean? That means that some drugs, all drugs have a certain percentage of protein binding. The higher it is bound to protein, the less has a pharmacological effect, is free. So if a drug is 50% protein bound and you give them 10 milligrams, 5 milligrams is going to be bound to protein, 5 milligrams is free to be able to be used by the body. Why is this important? Well, if a person has a low protein, who would have a low protein, a low albumin? You check your protein level with your albumin levels. Will be in your serum, your blood work. So low protein, malnourished person and the elderly tend to have low albumins. So if you give a highly protein bound drug, like it's 80% protein bound, so the pharmaceuticals, when they calculate the dose and when it's recommended dosing, they are dosing it with in mind that only 20% of the milligrams administered will be available for a biological or pharmacological effect. 80% of it's going to be bound to the protein. So you have a person that you give an 80% protein-bound drug, and they have very little protein. Their albumin is super low. They're elderly and malnourished. So rather than it being 80% protein-bound because they don't have enough proteins to bind it, maybe it's 50% protein bound. So rather than this, let's say 10 milligram drug that you only expect 2 milligrams to get into the body, but they have so little protein that 5 milligrams gets into the body. So it can cause toxicity very easily. I hope that makes some sense. And when you do your activity, it should help you some more. Okay. So drugs can move over the blood-brain barrier and the placenta. Not all drugs can go across the blood-brain barrier. It is a semi-permeable membrane to protect the brain. Only drugs bound to protein or highly lipid-soluble can cross. So as we go through your body systems and in your med-surg, and we talk about the pharmacology with it, drugs to treat things in the brain have to be able to cross the blood-brain barrier to be effective. And then any drug that can cross the blood-brain barrier is going to cause symptoms in the central nervous system. Then again, drugs crossing the placenta. Lipid-soluble and insoluble are able to cross the placenta and affect the fetus. So that's what decides the pregnancy cautions on drugs. Pharmacodynamics. I mentioned it's the drug's action on the body system. You have receptor sites that react with certain chemicals to cause an effect in the cell wall. They're called agonist and antagonist. I will touch on these, but we won't go into those more until we get into Pharm 1 this summer. There's drug enzyme interactions, and there's okay, that's all I'm going to say there. Okay, agonist and antagonist. And agonists, these have to do with receptor sites. The drugs interact directly with the receptor site, or the drug blocks the breakdown of natural chemicals that are blocking the site, so other chemicals that stay on site for a therapeutic effect. And as we talk about drugs, we'll talk about it being an agonist or an antagonist on certain sites. Antagonists block the receptor so there's no reaction or prevents it. So there will be I'm not going to get into it right now because I don't want to confuse you. I think of agonist as egging it on. It helps that receptor site, it eggs it on. Antagonist, it goes against it, it blocks that receptor. So that's how it has its pharmaceutical effect, whether it's a receptor that you want to work, if it's a receptor that you want to block whatever medical, it's causing whatever medical issue it is. Okay, half-life. Students tend to have a problem with half-life, and it's really not so hard. It's affected by metabolism and excretion. A drug goes through many, many half-lives until it's 90% eliminated. So the half-life, you give a drug, it's what decides your frequency of dosing on a drug and when it's going to peak. So you give a drug and it peaks. So you say a drug has a half-life of 4 hours. So at 4 hours, that drug has reached its peak and it starts to come down. And every half-life, so if it has a 4-hour half-life, at 4 hours, it's half the dose you administered has peaked and it's coming down. Another 4 hours, it's cut in half, and in 4 hours it cuts in half, and it keeps cutting in half whatever its half-life is. So a half-life of a drug, if a drug has a half-life of 4 hours, this drug is going to be administered frequently, because if you want to sustain a level, it has to be given at that half-life to keep it going. So if a drug has a half-life of 8 hours, a drug has a half-life of 24 hours, that's going to decide its administration. What other things affect a drug in the body? A person's weight, their age, their gender. Males and females have different percentages of fat naturally on their body, and muscle in their body, so that affects absorption of drugs. Physiological factors such as their protein levels, their absorption, like what their gut, do they have dumping syndrome? Have they had surgery where they've had part of their stomach removed? That's going to affect absorption through the gut. Pathological factors, genetic factors, immunological, psychological, environmental, tolerances, accumulative effect, drug-drug interactions, drug-food interaction. As we talk about drugs, as you learn in pharmacology, I will bring up what you need to understand on that particular drug. Other things like your site of absorption, how the drug is distributed, how it's excreted, drug-food interactions. Sometimes foods can increase or decrease or delay absorption of a drug. Drug interactions. They can have a potentiation, antagonism, and incompatibility. Potentiation means it increases the potential of the drug. This drug may not have any actual effect, it just enhances the effect of another drug. So it potentiates. Antagonism, it blocks, it goes against, antagonizes, it inhibits the effect of another drug. Incompatibility, two drugs mixed in a syringe result in a chemical reaction. Neither drug can be used. You haven't administered drugs yet. There are compatibility charts. Pharmacies now should put labels on things, which especially happens when you're going to give, like there's some drugs you cannot dilute with dextrose or saline. If you go to mix it with saline and it can only be mixed with dextrose, you get this solid thing that forms in your syringe and you know you've messed up. The worst thing is to give an IV drug with something IV that's incompatible. If you haven't checked your incompatibility chart and you go to hang like an antibiotic, a piggyback into your IV, as soon as that drug hits the medicine in or the fluids in that tubing, it just causes a concrete. It's pitiful. Anyway, this slide just talking about pharmacokinetics and pharmacodynamics, just going through all the different factors that impact drug absorption, getting it to where it needs to be, deciding dose. Polypharmacy is drug interactions, frailty. You probably heard polypharmacy terminology used in the nursing homes. That is a problem with people are on so many medications for different purposes, but then there ends up being interaction between them that may inhibit, enhance, or worsen things. So a few little questions here. Check your knowledge. What happens to a drug from the time it is introduced to the body until it reaches the circulating fluids and tissues? It goes through the pharmacokinetics, which is absorption, metabolism, and excretion. And it's impacted by pharmacodynamics, receptors, ion channels, enzymes, and the immune system. 2 patients are receiving injections of penicillin G. One patient is a male, 35 years old, and weighs 165 pounds. The other patient is female, 18 years old, weighing 125 pounds. You know that you will see the effects of the drug first in the male patient. What is the rationale for this? Men have more vascular muscles than women. When giving IM injections, it is important to remember that men have more vascular muscles, so the effects of the drug will be seen sooner in men than in women. And that is the end of this lecture recording.